Hello everyone, so now we continue with our discussion to crack down the questions into small simple lines. So now we will continue with the GI system. Let's say you see a 36-year-old man comes in with dysphagia, right? Difficulty swallowing. So you do exam, there's white flakes on the tongue and soft palate, and there's bilateral red erythematous fissure on the angles of the mouth, okay? So, and the patient has an HIV, by the way, of course, HIV. What's the best next step? This one, you want to do oral PO, fluconazole. Okay, why? Because this is possibly Candida esophagitis. And that brings us to the discussion of esophagitis in HIV patient. So there are three different types that are most important high yield. We have this Candida, the one that we talked about. You treat with fluconazole and usually involve the entire esophagus, and you have pain with solids more than liquids and associated with oral thrush as well. When you do EGD, you are going to see white exudate cottage cheese esophagus, and the biopsy you will see pseudohyphae in the mucosa. The second one is cytomegalovirus, and the third one herpes simplex. What's the difference? So cytomegalovirus causes sharply demarcated linear ulcers in the distal 1/3 of esophagus, and you have intranuclear inclusion on the biopsy, and causes odynophagia, very painful, and substernal pain. And you treat with IV ganciclovir. But herpes simplex causes well circumscribed shallow ulcers that stain positive for herpes simplex virus on the culture, and causes oral regions sometimes with abrupt onset, and treated with acyclovir. So the only one that causes odynophagia with white stuff, and this is the Candida. So you give oral fluconazole. Okay. So now you have 18-year-old man comes in with all sorts of pain with swallowing. Okay, dysphagia as well. Taking ibuprofen. What's best next step? DC, ibuprofen or NSAID. So this is pill-induced esophagitis, medication-induced esophagitis. Now you could ask me, is it NSAID is the only one that causes esophagitis? Of course not. There's potassium can cause esophagitis, like difficulties, esophagitis, like dysphagia, tetracycline, and iron, and bisphosphonate. These all can cause esophagitis, usually due to localized chemical injury to the esophageal mucosa. How does it present? The kind of presentation: drug ingestion with minimal water at bedtime, and it can cause retrosternal burning chest pain and cause odynophagia leading to dysphagia. And the diagnosis is a clinical presentation history, and you can do endoscopy in severe cases. And the treatment is just discontinuing the offending drug immediately. Alright, now you have somebody who's 33-year-old man, HIV positive, came in with dysphagia, right? Difficulty swallowing. What would you do? You need to do EGD to differentiate these three that we discussed about: Candida, herpes simplex, and cytomegalovirus. You want to know what's causing it so that you treat it properly. Now we talked about HIV esophagitis. What could cause that? There are three viruses. How about if I give you 22-year-old man came in with dysphagia and have asthma? So asthma, dysphagia, asthma, allergic rhinitis, all of that. Okay, and then you see like somebody drooling, speaking in broken sentences. You feel like food pullus in the esophagus. What is diagnosis, or what you would see on EGD? This one called eosinophilic esophagitis. And now they didn't ask you about diagnosis. They told you what EGD finding you see on that. You see multiple esophageal rings and furrows, and that's what you see in eosinophilic esophagitis. So you could ask me, why is that? This is T helper 2 mediated inflammatory response triggered by food antigen. Okay, usually common in people who already have allergic reaction like asthma, just like asthma of the esophagus. Okay. Asthma, eczema, food allergies, allergic rhinitis common, and they present with dysphagia, heartburn, epigastric pain, regurgitation, food impaction. You diagnose with endoscopy and esophageal biopsy. You see eosinophil more than 15 per high power field, and then you want to exclude other alternative diagnosis like achalasia and infection. How do you treat it? You treat with elimination diet. Try to see what food triggers you. You give PPI and steroid, topical steroid. So you give PPI, topical glucocorticoid. Okay, that's the management of eosinophilic. Okay, this is for eosinophilic esophagitis. Okay. Now this is interesting case dynamics. So you see 77-year-old came in with have chronic constipation, right? He has chronic constipation, and now they tell you the patient is having urinary and fecal incontinence. Okay, so they tell you, okay, what's the best next step in this patient, or why is that happening? This one is happening because of overflow of stool. Okay, so this is the constipation that causes fecal incontinence or diarrhea kind of symptoms. So it's interesting dynamics. So now this is talking about fecal incontinence. What causes fecal incontinence? 3 things. Okay, trauma, if there is vaginal delivery, obstetric laceration, or somebody has surgery like anorectal surgery or hemorrhoidectomy. Second cause is neurologic causes like diabetic neuropathy, multiple sclerosis, spinal cord injury, and dementia can cause that. And there are chronic diseases that can cause fecal incontinence, like constipation is one of them, hemorrhoid with rectal prolapse, inflammatory bowel disease, infiltrative disease as well. There's systemic sclerosis, pelvic radiation as well. This can cause fecal incontinence. Okay. So how do you manage this fecal incontinence due to constipation in this patient? The way you manage it, you manual this impaction, okay, and a chronic bowel regimen to prevent recurrence. Okay, so that's why anytime you have somebody with fecal incontinence, you should begin with perianal inspection and digital rectal exam. Okay, all right. And now you have somebody who's 77-year-old, evaluated for gallstone, and the patient had benign prostatic hyperplasia, lower abdominal discomfort, and difficulty voiding. Okay, you see exam, there's suprapubic tenderness to deep palpation. So what would you, okay, and then on top of that, there is gallstones. Okay, ultrasound, they did ultrasound, there's gallstones. Okay, and they tell you what's the best next step. Do you remove the gallstone or you do nothing? This patient clearly doesn't have issue with gallstone, it has issue with BPH, urinary incontinence, all of that. But so this one, nothing, reassure for the gallstone wise. That's what they want. Okay, treatment is nothing. Now that brings us to the discussion of gallstone, management of uncomplicated gallstone. If you just see it on imaging without any symptoms, then you do that thing. If you haven't done the imaging, you probably wouldn't do anything. Okay, so no specific treatment. If there is a gallstone on imaging with typical biliary colic symptoms, then you just do pain management. You can do a prophylactic cholecystectomy, usually elective and laparoscopic, or you can do cholestyramine, ursodeoxycholic acid, for poor surgical candidate or patient refusing surgery. How about if you have gallstone with atypical symptoms? If there's atypical symptoms, then you can look for other causes. You can give cholestyramine, and you can do cholecystectomy if nothing helps. So you try other things before cholecystectomy. How about if there's typical biliary symptoms without gallstone on imaging? What would you do? That's a tricky one. This one you do cholecystokinin stimulated cholecystography to evaluate for functional bladder disorder, and you do cholecystectomy if patient have low gallbladder ejection. Okay. Now you see somebody who's 33-year-old came in with epigastric pain. So you test for H. pylori, positive. you do EGD. There is 1.4 centimeter ulcer. Tell you what's the best next step. Do you biopsy or not? Of course you do biopsy. So you do biopsy of the ulcer. Multiple biopsies of the ulcer. That's the question what they're asking about. And now that brings us to the discussion. When do you repeat the endoscopy with biopsy? Even if you did endoscopy, you were not planning on biopsy. You repeat it to do just to do the biopsy. You repeat it if there is inadequate ulcer biopsy. If you didn't do adequate one, go repeat it, do adequate one. Okay, patient in endemic area like Asia, Latin America, somebody doesn't take an NSAID, okay, you can do that. Someone who have a history of gastric cancer, or there is H. pylori or gastric atrophy, somebody have age more than 50, ulcer more than 2 centimeter, or absent duodenal ulcer, require higher acid secretion and lower risk for gastric cancers. Now in this case you see 44-year-old man comes in with multiple ulcers in duodenum. So there is only one disease that causes multiple ulcers in the duodenum. 2 in the duodenum and 1 in jejunum. So this was the best next step. This you check gastrin level, because gastrinoma is the only one that causes a lot of risk for a lot of ulcers. So you really want to rule that out because it's very high yield. Okay, so if you suspect gastrinoma, you do endoscopy with multiple stomach ulcers and thickened gastric folds. That's what you're gonna see, multiple ulcers, thickened gastric fold. Then you check the gastrin level. Okay, so after you check the gastrin level of PPI therapy, of course you stop the PPI for 1 week and then you check gastrin level. If it is less than 110, this is not gastrinoma. If it's above 1000, this confirmed gastrinoma. You do gastric pH of PPI therapy for 1 week. If it is more than 4, this is no gastrinoma. If it's less than 4, this is further testing to localize the gastrinoma, and then so that you take it out. But if the gastrin level between like 100 to 1000, then you do secretin stimulating test to see if the gastrin increase with that. Then you further test to localize the cancer. If it's negative, then nothing to do. All right. Now you have someone, 41-year-old woman, or came in with a recurrent nighttime heart burn awakening, okay, nocturnal awakening of regurgitation. What would you do? This one daily PPI, okay. This patient is young, you know, just do daily PPI because there's no alarm symptoms. When do you do endoscopy, not just PPI? If there is alarm features for GERD, what are the alarm features? If there is age more than 50, if there is difficulty swallowing, weight loss, anemia, melena or hematemesis, and failure of PPI trial after 4 to 6 weeks. Okay, so if you're losing weight, losing blood, you know, and losing hemoglobin, so all these things can cause that. Okay. Other features indicate severity of GERD but doesn't require PPI. If there is nocturnal symptoms, if there is extraesophageal manifestations, or chest pain, non-cardiac chest pain, not just difficulty, not just heartburn, this confirm that it's PPI. Okay. All right. Now this case is interesting. Somebody who having heartburn, okay, GERD symptoms, like I say, 35. Having GERD, like heartburn, you know. So what do you give him? You give PPI, right? Like this patient in the above question. You give PPI. Now the question is still not helping. What's best next step? You do twice daily PPI, okay? You do PPI therapy twice daily. So how do you manage GERD? Manage GERD if there are symptoms, GERD symptoms, like there's substernal burning or regurgitation. You see if there's any alarm features or multiple Barrett esophagus risk factors, like Is there any losing weight, losing blood, vomiting, iron deficiency anemia, dysphagia, okay? Or somebody male or GERD more than 5 years, family history, white ethnicity, hiatal hernia. Any of that, you just do endoscopy, okay? Any risk factor. Okay, if you rule, like somebody had heartburn and you rule out the risk factor, like it's younger than 50, no family history of cancer, not a smoker, female, no history, no iron deficiency anemia, no blood in the stool, labs looks okay. What do? Just assess the symptom severity. If it's mild, less than twice a week, less than twice a day per week, then you do antacid, calcium carbonate, and lifestyle changes, okay, or H2 receptor blocker. If it's severe, more than 2 times per day per week, then you do PPI plus lifestyle changes, and you can start low dose and you increase as needed. Okay, so this is what we talked. We talked about, this is the review. We talked about heartburn. It's a very interesting topic. We talked about daily PPI for heartburn. We talked about gastrinoma. Biopsy the ulcer is important, and nothing for gallstone. And constipation causes fecal incontinence. Discussion. Steroid for eosinophilic esophagitis with PPI. Multiple rings. EGD for HIV, asthma. Discontinue NSAID for NSAID is dysphagia. Fluconazole when there is white rash and dysphagia and HIV. So this is what we talked about: HIV dysphagia, asthma dysphagia, NSAID dysphagia. Talked about heartburn, and that concludes our session for today. Thank you for listening.